So, good morning, everyone. Welcome to the National Hispanic Council on Aging webinar on the obesity status among Latinos. My name is Christine Perez, and I'm NHCOA's Director of Programs, and it's my pleasure to be moderating today's virtual event, which is supported by the Administration of Community Living, also known as ACL. For over 50 years, NACOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. Our commitment to our mission has only been emboldened in the face of ongoing health disparities that continue in our communities. This webinar is an opportunity for us to review the current status of obesity among Latinos and recommend research informed strategies to help address this complex public health issue. So, to begin this virtual event, it's my pleasure to introduce Dr. Janita Cruz. She's the president and CEO of the National Hispanic Council on Aging. She's one of the nation's foremost advocates and spokespersons for diverse older adults. And she has also been recognized for her commitment and leadership on behalf of diverse older adults nationwide. So, welcome, Dr. Cruz.
Thank you. Thank you, Christine. Good morning, everyone. And thank you for those kind remarks, Christine. So happy to see all of these speakers here, such amazing leaders, talent, and advocates for our community. So thank you for making it here this morning. And so, obesity is a widespread issue in the United States. It's a huge public health challenge that continues to grow, something that we have been very concerned about, have been working on this issue now for some time, trying to understand, what is getting in the way, what is causing so much obesity in our communities, and coming up with solutions. We've conducted surveys, as an organization, have conducted focus groups across the country to try and understand, what is getting in the way and to help us come up with solutions. So this is work in progress, and this webinar is another step in that progress. But nearly half of the adult Latino population is living with obesity. This is a huge problem that leads us into other complications that we all know about: diabetes, cardiovascular disease, and others. So clearly, a huge concern, both at the individual level, as a societal level, as in our financial system. It's also putting a huge strain on our financial healthcare system. So and we know nutrition is clearly an important element to deal with the challenge. We know that exercise is also another important solution, and we encourage that. We advocate for that. Over the years, we have spent our time and energy, encouraging our communities to do that. But we know that doesn't always help everyone. We know that that's an important strategy that we should all maintain every day, regardless of our weight. But we also know that it's not enough for some individuals, and for those individuals who require additional help to lose the weight, there are other options, and science fortunately has advanced to the point that we have new solutions to the problem. And we should all have complete access to the wide continuum of care, which includes anti-obesity medications, and other other medical treatments. So and in this process, diverse populations and older adults often face greater hurdles accessing the full continuum of care. So Medicare, for example, right now does not cover over-the-counter anti-obesity medication. So, and that is a problem, keeping our older adults from effectively accessing the full continuum of care. Um, and sometimes for some of our communities, uh, the neighborhoods where they live makes it difficult to go out for walks. So, unfortunately, not everyone has access to safe neighborhoods, and so I think it's important that we keep that in mind. Food deserts is also another issue in some rural communities and in even some urban communities. So I think that those barriers are keeping some communities from accessing some of the strategies that many of us in the health area advocate for. So we know that there are solutions, and each one of you will bring up some of those issues and solutions in today's webinar. I think we have great minds, brilliant minds here with us this morning who will present some of the most up-to-date information that we have available to deal with this issue. And so the idea is that that there are solutions to this obesity epidemic, but we have to work together. We have to work together. We have to bring our brains together, advocate together, educate our communities together, and of course, individually, we each have to, play our role. We have to also take action, look for information, and do the necessary steps to ensure that we're leading a healthy life, a a healthy life that will keep chronic illnesses away from us as much as possible. So with that, I want to say thank you again to all the panelists who are joining us today. Thank you to all the participants who have connected, and thank you to the ACL for supporting this webinar this morning. So enjoy the rest of the program, and turn it over to you, Christine. Thank you.
Thank you, Dr. Cruz. And before starting with the next speaker, I wanted to let know the other panelists if you can turn off your camera and mute yourself. And as soon as we go to present you, you can unmute and turn on your cameras as well. Thank you. So thank you again, Dr. Cruz, for your opening remarks. And with us here today is also Mr. Robert Blancato. He's the president of Metz, Blancato and Associates. He also serves as the national coordinator of the bipartisan 3,000-member Elder Justice Coalition. He's also the executive director for programs for the National Association of Nutrition and Aging Services, and also the national coordinator of the Defeat Malnutrition Today Coalition. NHCOA is also proud to know Mr. Blancato as a member of our board of directors. So welcome, Mr. Blancato.
Thank you very much, Christine. Good morning, everyone. And let's go over to the first slide, if we could. And I am proud to be, let's go beyond that. Next slide. Okay, so it's a pleasure as a board member to be invited today. And thank you, Christine, Dr. Cruz, for having this important webinar. And we are focusing on obesity, the public health crisis affecting more than 40% of the population. A serious chronic disease that's intergenerational in terms of who it's affected, the young and the old. And research has identified obesity disproportionately affects people with Hispanic heritage. Next slide. More specifically, there are factors that contribute to the increased prevalence, including genetic predisposition, acculturation, environment, family dynamics, and socioeconomic status, as Dr. Cruz mentioned. Next slide. So by 2028, we have to address this issue in part because of the tremendous growth of the Hispanic population of those 65 and over, expected to be the largest racial ethnic minority in this age group by 2028. And it will continue to grow beyond that much more quickly than other ethnic minority groups. Next slide. So the focus against this backdrop, we want to talk about how to successfully manage obesity in the Latino population. We need culturally tailored interventions that are as personalized as possible is one certain key. The impact of genetic, dietary, cultural, and socioeconomic factors must be considered in an obesity care and treatment plan, and also the involvement and participation of key family members in the development of culturally sensitive intervention strategies, including bilingual and bicultural staff who provide the care. Very important. Next slide. As Dr. Cruz mentioned, it is about good nutrition and healthy aging. The role of nutrition not only in obesity care plan, but in the broader goal of healthy aging, which starts with good nutrition. Let's look at those linkage issues tied to obesity. Food insecurity, which is on the rise in the United States, linked to obesity and diabetes. Acculturation can and does impact dietary patterns of Latino adults. This leads to the higher intake of unhealthy foods, which over a lifespan can and will lead to obesity. And research has found that Hispanic women who are food insecure are 29% more likely to be overweight and obese. Next slide. Moving to treatment, as was mentioned, there's great attention being focused on anti-obesity medications. Congress is considering allowing more of these medications to be covered by Medicare under a bill called the Treat and Reduce Obesity Act, which is awaiting action in the House. Next slide. In my capacity as the national coordinator of the Defeat Malnutrition Today Coalition, of which NHCOA is a valued member, we contend three basic things. One, obesity is a form of malnutrition. Two, anti-obesity medications alone are not enough. And three, medications must be coordinated with good nutrition and nutrition education and counseling, including lifestyle counseling and nutrition counseling that are done by dietitians. Next slide. So as we look at some of the obvious solutions to obesity, nutrition counseling, physical activity, behavior modification, we have to face the reality that Dr. Cruz touched on. Low-income households lack access to healthy foods, especially those in food deserts or lack transportation. Physical activity and behavioral modification programs are often not easily available in under-resourced communities. And older adults may have physical disabilities that reduce their ability to shop or cook for healthy meals. Next slide. So as we address this growing issue of obesity in Hispanic and Latino communities and elsewhere, our solutions must promote health and nutrition equity. Nutrition and health are not separate categories. And I'm proud to co-author an article which you see on the right, in Health Affairs, to promote health and health equity include quality nutrition care as part of an anti-obesity medication therapy. Next slide. So we have activities that are going to happen this year. Congress should, for example, pass the Older Americans Act reauthorization, and in doing so, provide increased funding for congregate and home delivered meals, allow more programs to offer food as medicine, ensure more culturally appropriate food to be provided, and to expand malnutrition screening and ensure healthier food is provided with federal funds. And this process is underway. In fact, tomorrow in the Senate Health, Education, Labor, Pensions Committee, they're going to mark up the Older Americans Act of 2024. Next slide. Congress also should pass the Medical Nutrition Therapy Act to expand MNT under Medicare to all individuals diagnosed with obesity, including those on medications and those who have done weight loss surgery. We must pass the Treat, Reduce Obesity Act that I mentioned earlier, and we need to mandate universal screening for food insecurity in all federal health programs, as the White House Conference on Hunger called for back in 2022. Next slide. Congress should also extend those telehealth and telemedicine programs that were established during the pandemic. They have been of immense value to rural and or remote population areas who cannot access health care services, including older adults with chronic diseases. We must continue to close the digital divide and expand broadband access as the Infrastructure Act provides. And we must expand the ACP program, which allows low-income individuals to afford internet coverage. Next slide. So as a nation, we need to be more proactive in investing in prevention. Some obesity can be prevented through good nutrition, physical activity, and behavior changes, but they have to start earlier in life. And as we focus on issues around health equity, as we should, let's examine and commit to closing the existing disparities that exist in areas like access and affordability to health care or social care services like nutrition. As an organization, NHCOA must continue to fight to ensure that as policies and programs move forward to treat obesity, priority attention is given to the Latino population with their documented higher percentage of obesity. I look forward to us working together on this important issue, and thank you for the invitation this morning.
Thank you, Mr. Vencato. So, to begin today's agenda, let's review the greater context of the United States. According to the Centers for Disease Control and Prevention, also known as the CDC, obesity is an epidemic in the United States, and it has major implications for the health and the well being of the population. Obesity is one of the most insidious chronic diseases that is facing all generations of Hispanic and Latinos. Our first speaker is Dr. Henry Pacheco, that can speak more about this issue as well. He is a physician and also an advisor to the National Hispanic Council on Aging. Today, Dr. Pacheco will highlight the obesity landscape among Hispanic Americans. Welcome, Dr. Pacheco.
How are you? Thank you so much, Christine. It's a pleasure to be here. And no, thank you so much for allowing me to participate. So let me go ahead and briefly start my presentation, which may be interrupted frequently by bouts of coughing and sneezing. I mentioned to the host that last week I was affected by COVID, and I'm in that recovery phase. But in any case, to get into obesity among Hispanic Americans. First of all, yeah, if you could go ahead. Oh, yeah, you're there already. All right. So what is obesity really? And essentially, it's just a abnormal and excessive fat accumulation that presents a risk to health. It's also considered a chronic disease, actually. So that's what we're referring to when we discuss the obesity. And in order to have a platform we can refer to, that we can measure, BMI classification has been tool that to estimate and screen for overweight. Every BMI is really defined as weight which is in kilograms divided by the height, meters, and charts have been made and been used for many years. And within those charts, anyone who is in a BMI of over 30 is already considered obese, and of course, for 40 would be severe obesity. So we use these charts particularly to determine, the person is obese, and if so, what progress or she might be making in this. They deal with this challenge. Next slide. Let me start by introducing the levels of obesity that we find in Hispanics. In this chart, we compare non-Hispanic whites, Hispanic blacks, and of course, Asian and Hispanic. At the very far right, the light green is the Hispanic population. As you can see, we have passed the 30% obesity rate in both categories, significantly more so among women. We can safely say that all of us, whites, blacks, are pretty much in the same boat. Very bad situation when it comes to obesity. Of the folks doing best are the Asian population that is far controlling their rates of obesity, and they seem to be doing, and at least in comparison to all of their other Americans here. So you can see our situation is just as bad across the board. Next slide. I also wanted to briefly mention that there are some differences in the levels of obesity on Hispanic subnationalities, let's say subgroups. Some are a little bit better than others, and some, of course, worse than others. This chart, it's probably difficult for you to see unless you're within inches of the screen. Shows, Cuban, Dominican, Mexican, Puerto Rican, Central South American populations. You can see there's a variation where Puerto Ricans seem to be at the highest prevalence of obesity, and let's say South Americans at the lowest. And this has something to do with genetics. Those folks that have more Native American or Indian, let's say, and the African blood seem to be more prone towards obesity, and it also could be, not it could be, but it is also socioeconomic. For example, South Americans, I believe, have slightly their socioeconomic standing. So therefore, have the benefits that their incomes provide in the management of any clinical issue. There are slight differences among the various subgroups. Puerto Rican and Mexican, who happen to be the majority of our population, Latino population, are significantly impacted, as you can see. Slide. Of course, here we see childhood obesity rates, and we can see how Hispanic childhood obesity rates are very high, which is incredibly sad because this is mentioned a chronic disease, considered a chronic disease. These children, unless radical changes do take place, will go on to become obese adults and carry all the burden that comes with it. Unfortunately, Hispanic children have very high obesity rates compared to the rest of the population. Slide. I particularly like this slide because it shows progression of obesity for the decades. Some believe that the obesity epidemic in the United States started in the early 70s to the 1980s, though some have placed obesity at even earlier decades. In any case, write this right here. In any case, as you can see, it started in the early 80s, 70s. Thereafter, there was a very rapid increase in obesity in the nation among both genders and across most population groups in the U.S. What triggered this epidemic in the U.S.? There had been a reduction in physical activity, manual labor in those decades. Also, growing interest in physical activities. As you may remember, Jim promoted jogging, and we all started jogging. By the way, Jim Vicks died at the age of 52 or something like that. Heart attack while he was jogging. It's an unfortunate corollary to someone who really got all of us interested in jogging. So, of course, there's the home calisthenics followed by Jane Fonda in the 80s. So on, there's a good number of figures that would also influence our behaviors in a positive way. At the time, there was also an increase use of cars and public transportation. All of that is making us less and less active. Dietary changes also started to occur and may account for the this incredible rise of obesity over the decades, especially high content foods were beginning to be highly introduced. Fat, although in some ways also fat consumption did actually fall, but then we saw the growth of carbohydrates and sugar. Surely this consumption of sugars, sugary drinks, and everything sugar. And of course, then I think it was in the end 70s, there was a shift to an inexpensive a high fructose corn syrup, which is present in everything, and the along with the availability and consumption of sugary sweetened drinks, and so all of these leads to one group of foods known as ultra-processed foods. That's believed to be among the most significant contributors to our obesity epidemic. Ultra-processed foods are just, some people decide as substances that are edible, highly processed, highly manufactured, very tasty and very pleasant. So ultra-processed foods are ever present in pizza, cold cuts, just about chicken nuggets, anything you can think of now, practically, unless it's grown in a plant or something like that. It's all in a tree or is walking around in nature. They're all ultra-processed foods are highly suspect for being responsible for the obesity epidemic. Therefore, it appears that the high consumption of ultra-processed foods can, for many people, makes up to 50% or more of their diet. The advent of fast food restaurants also have made it one of the most important dietary factors responsible for the epidemic in the U.S., for the obesity epidemic. Fast food restaurants became ever present. Every corner had on 2 or 3 fast food restaurants. People just left work, went to eat a quick meal. Parents left work, stopped by a fast food restaurant, have a good meal that their children will eat readily, without having to put up a fight at the table and without having to spend, at least an hour cooking foods that then you have to fight with the children to eat them. And also at the same time, I don't recall all of them, but I don't recall the exact time frame, but also some many federal policies and subsidies to farming, and that essentially led to the overproduction of high calorie, carbohydrates, and definitely ultra processed foods. So that line is very impressive, and it shows the growth of the epidemic of obesity in the nation. Next slide. What do we have? We have that 1 in 3 adults, over 30% are overweight, and 2 adults have obesity. Adults in 5, have obesity. That's like a 40 greater than 40%. And then we get into almost 10% that are severely obese. That is very serious disease. If you think about it, severe obesity is a very serious disease. Likewise, in children, we're getting very close to 20% being overweight, and definitely 20% have obesity. Almost 1 in 5 children from the age 2 to 9 have obesity. That is, extremely sad, because these children will go on to become obese adults in most cases, I would say, and it's just a terrible future for them. Next slide. Just contribute to obesity. Mr. Blancato mentioned them, and of course, there's many of them. Dietary habits, nutrient-poor foods, reliance on high-calorie, highly processed foods, fast foods, high sugar content foods, ultra-processed foods, all in fast food restaurants. They all contributed to our dietary habits. Physical activity, we became more sedentary, used more cars, more public transportation, and of course, even before social media and all that, children and adults were already sedentary, and now they really are sedentary because of the addiction to social media and gaming and computer games. So are very physically inactive. Multiple socioeconomic factors contribute to obesity among Latinos: poverty, food deserts, as mentioned, the inability to the lack of availability of healthy foods, and the influence of 7-Eleven type of stores, bodegas. You can get mostly highly processed foods and not the natural plant and animal products. Biological factors, yes, there are some genetic variations among Latinos that seem to be contributing to obesity just because the genetic makeup. A few biological factors, but mostly done due to dietary and physical inactivity and socioeconomic factors that contribute to this. Slide, please. Of obesity are many, and many of them cascade one upon the other. Obesity is definitely opens up the door to diabetes type 2. It's almost automatic. Obesity also leads you to hypertension, lipidemia, high fat circulating in our blood, and then blocking arteries. Also, these things lead to kidney disease. Obesity leads to liver disease, fatty liver, and of course coronary heart disease, which is indeed many times the ultimate killer. There are also other things such as degenerative arthritis, arthrosis, painful walking, painful standing, painful doing any activity because you have back pain, chronic back pain, significant amount of disability as a result of obesity. Also sleep apnea, and sleep apnea has its own consequences in terms of bringing out cardiovascular problems such as hypertension and even cardiovascular fatigue. Disability, extensive amount of disability that we see around in the community, especially once adults reach past their and all that, they start becoming very disabled. And cancer is also linked to obesity. Next slide. There's also social consequences to obesity. There's a lot of bullying going around. Overweight children and even adults are constantly being bullied. Also bias in employment and other social situations. Many of these folks are not given job opportunities because they're considered to be, they're judged by their looks, and the overweight look makes them look, not appropriate, not attractive in their employment. They even make comments about whether they're smart or not. Which of course leads to low self-esteem, depression. There's a significant stigma attached to obesity, and obviously discrimination and the loss of income, days of work because of the obesity and disability they pain. So significant social consequences to obesity, which are really weighing down on our population and making things even more difficult for a population that already has to fight to struggle every day to make ends meet. Next slide. So this is just a list of who needs to be involved, what needs to be done to stop or reverse the obesity epidemic. Very hard disease to fight, very hard epidemic to control. For it really requires the participation at every level, individuals at every level of society, every political policy structure. Definitely, number one is personal responsibility for adults and for those of us who make our own decisions. At which we have to say, wait a minute, do I get a Coke or do I get a water? That's just as easy as that. And then we have all of those learned models and things like that leads us to select a Coke or a soda. It's as role models. That's very important. I see it in supermarkets all the time where parents are really terrible role models for their children. Families, grandparents, caretakers. Grandparents take a lot of children. Not too long ago, a friend left her little daughter, 6-year-old, her mother. She went to work overseas. And the first thing the mother said, "Oh, your child is so thin. Don't worry about it. I'm going to take care of it." And the child looks more than fine to me. So for the grandmother to say, "Your child is so thin, I'm going to take care of it," means she's going to lead that child to obesity, just to put it bluntly. Care providers, they're more proactive now than they were when I was in full practice. When I was in full practice, many healthcare providers make a note on the chart that obesity was there, along the list of conditions, diseases the person had. Obesity just wasn't listed, the other weight was looked into and this and that. Many community venues, people need kinds of community venues to get information, where to get activities, IMCAs, to get physical activities, to be able to exercise in pools. Of course, all kinds of policy programs need to be instituted by the council and state level officials. Ensure that appropriate foods are being passed out in schools, and that that appropriate curricula includes perhaps back to the gym class, or at least a physical activity, maybe twice a day for students, just running around or something like that. If they're physically active, that need to be put back on, because many of these programs have been removed. Of course, pharmaceutical companies right now, they are really doing their best, and they have brought a significant relief to patients with the implementation of Ozempic. I mean, with the discovery or manufacture of Ozempic and Wegovy, which to be almost miraculous in addressing not just diabetes but obesity. So now they are doing a great job. These pharmaceuticals are expensive; they're not available to everyone, and we shouldn't just depend on pharmaceuticals to help us. But they are there. Ozempic, Wegovy are being massively used. They will be used more, except they're very, very expensive for anybody who is not insured. Nevertheless, they do bring a great deal of hope. Thank you so much. There's much to be said about obesity. It's a horrible epidemic. It's a horrible disease. We're just not really treating it as such. And we definitely need to be much more aggressive with this condition. Thank you so much, Christine, and the folks at NHCOA for allowing me to participate in this wonderful webinar and one addressing such a serious disease in the Hispanic community. You.
Thank you so much, Dr. Pacheco, for this wonderful presentation. And at the end of the panel session, we will have a question and answer session. So please feel free to write your questions in the chat box, and we will make sure to discuss them at the end of this session. So next, we will review the findings from NHCOA's obesity focus groups among Latinos. And we conducted these focus groups just to gather insights into Latino knowledge, attitudes, and behaviors towards the obesity issue and also its impact. So today I will be speaking about this issue briefly. So in our research, we gathered the opinion of 60 Hispanic adults, and we conducted these focus groups in New York, Florida, California, Texas, New Mexico, also in the DMV area known as Washington, D.C., Maryland, and Virginia, and also Puerto Rico. So when going to the questions that we asked our participants if they know of anyone living with obesity. And the majority of the participants reported being overweight or obese themselves, and also knowing or being related to overweight or obese people. They also all of them reported having a great difficulty in managing their weight. And also they reported a lot of physical and emotional effects or tolls in their own and other lives. Most reported that weight is usually discussed or treated related to other comorbidities or chronic conditions that they may be at risk of or may have already, just like Dr. Pacheco mentioned, diabetes, high blood pressure, high cholesterol, thyroid issues, among others. So when asking about their thoughts of obesity among Latinos, well, they generally agree that it is a growing problem that is affecting not only Latin American adults, but also children. They attributed this due to the sedentary lifestyle, especially that exacerbated during the pandemic, and also the general trend of people moving less and spending more time in front of screens like smartphones or TV. And they also mentioned the cultural factors for Latin Americans that were raised in regards to food and lifestyles in the US, and also the exercise too. Others believe that obesity is treatable and it's largely caused by lack of awareness and education. When we ask about what they think are the causes or contributions to obesity among Latinos, what they mention possible medical causes, for example, hormonal imbalances and genetics predisposition, as well as cultural reasons. And they mentioned other factors such as the food quality, negative lifestyle changes, the stress and loneliness for immigrants, also the mental health state. If they're depressed or are stressed, they usually eat more, the lack of health insurance, financial access, even the lack of education and for better health management. Most participants also noted that while it used to be the case that they will walk more and play outside as children, now life is very sedentary for adults and children. And again, they mentioned that people also cook less and eat out more, like going to McDonald's, dentists, other restaurants or fast food, and the business work schedule makes it harder for them to have healthy habits. And when talking a little bit more about the hindering factors, well, the main issue with weight loss for participants was the issue of sustainability. What I mean by this is that participants generally reported their relationship with weight as a roller coaster. And the main factors that prevented initial and or continued were genetics, personal and cultural eating habits, lack of discipline, the pandemic, COVID-19 pandemic, work, finances, among others. And also, a number of participants mentioned that they come from heavy-set families, and that they and their relatives have long struggled with obesity. And also, they had some trouble. They mentioned that they had some troubles in breaking dietary habits like a high sugar or high fat diet. This was also related due to the cultural or family sourced love of food. So in the next slide, we will be talking a little bit more about weight management discussion. And here we ask the participants what elements of the Latino culture make it easier to stay healthy. And they mentioned the affinity for community gatherings, like participating in community events and health fairs, doing barbecues, and inviting their families. More nature-based traditions, and less individualistic culture, and as well as outdoor activities and dancing as part of the Latin American culture that contribute to healthy habits like dancing Zumba. This is a very famous exercise that usually Latinos does, and I believe others as well. So when we ask participants about what elements of the Latino culture makes it harder to stay healthy, well, most of the participants uh, features of the Latino culture is that promote healthy habits have almost disappeared because of the general societal trends and the pandemic of staying at home, not doing exercise, or staying with their computers or smartphones, and again because of the lifestyle changes related to immigrating to the United States. And in the next slide, during the focus groups, we mentioned or we discussed that CMS pays for behavior therapy and bariatric surgery to address obesity, but does not cover medications to lose weight. And we wanted to hear more about participants' thoughts around this issue. And well, participants mentioned that it's very contradictory that CMS should cover some treatments or cover a more serious surgery and not the medicines required to maintain or control weight before or after it, or expensive diagnostic tests. And they've also highlighted that this approach is not considered preventative, and therefore it's not successful or in the best interest of the patient. So before ending the presentation, in regards to awareness and next steps, we asked participants if they knew of any treatments to treat obesity, if they knew it has a cure, and none of the participants knew about medications to treat obesity. But they knew about surgical treatments for obesity, such as the gastric bypass surgery, reducing the stomach size, and also they highlighted that it requires a personal effort and also the healthy habits. Otherwise, the effects are lost. And ultimately, the answer is to eat less and eat better. And it places a lot of emphasis on addressing the mental health issues underneath unhealthy relationships with food. And in the next slide are our obesity findings. For more detailed information, you can access our NHCOA website for the link of this report that has detailed information. You can find it in English and also in Spanish. So thank you. And once again, please feel free to write your questions in the chat box or during our question and answer session at the end of today's webinar. So to reiterate, obesity represents a significant public health concern, with 1/3 of adults classified as living with obesity in the United States. However, studies indicate that keeping active can help people stay at a healthy weight or lose weight. It can also lower the risk of heart disease, diabetes, stroke, high blood pressure, uh, among others, as well as reduce stress and boost mood. Inactive or sedentary lifestyles do just the opposite. So let's hear more from our speaker. He's Dr. James Skinner. Dr. Skinner is a professor emeritus in the Department of Kinesiology in Indiana University. Today, Dr. Skinner will highlight the importance of physical activity as it pertains to obesity. So welcome, Dr. Skinner.
Thank you. I'm very happy to be here today, and several, as you all know, this is not a simple disease. It's a very complex issues involved. But I did want to mention one thing, and that is a number of people mentioned about genetics and the importance of genetics. And I have to remind people that the rapid change in weight over the last 30, 40, 50 years is too fast to be due to genetics. It's more related to lifestyle. Now, there are studies that show that there are certain factors that predispose someone genetically to being overweight. And if you make a score for those scores of the genetic predisposition, there is, as the great, oh, excuse me, go back to the previous slide. If you add those scores, that the higher the score, the higher the weight for a given height. But the interesting thing is when they separate the total group into those who are active and those who are inactive, the people who are active with the same score way less than the people who are sedentary with the same score. So even though there is a genetic predisposition that is a factor, lifestyle can still affect that. Next slide. Now, rather than go into a lot of details, what I would like to mention to you here, the lifestyle is the most important in terms of obesity is exercise and diet. And here you see a study that sort of synthesizes all of that. If you look at the yellow score, the body weight, don't look so much at the other two. If you do diet only, after a year, you lose about 8.5%, this particular group. If you do exercise only, it's about 3%. But if you combine the two, you see the 8.5 and the 2, it turns out to be pretty much, if you do both of those, you'll lose more weight than either combination, either treatment by itself. So the important thing is that if you're trying to increase your performance and your health, then you have to do the exercise as well, because exercise is important for performance and for health, but it's not, you need to do the diet and the exercise for losing weight. Next. Next slide. Now, there's a national weight control registry of people who've lost weight and have maintained that loss for at least a year, if not longer. And the interesting thing is, if you look in there, that all of the people, most of the people who maintain that weight loss, they exercise on a regular basis, either vigorous, high intensity, or moderate. But the important thing is here is they made it part of their lifestyle. They lost weight by exercise and diet, but to maintain it, they have to keep active. If you do just diet, they tend to don't maintain it as well. So again, diet and exercise to lose weight, and diet and exercise is important to maintain that weight. Next slide. The important thing to remember, though, is that it's a total energy expenditure when we're talking about exercise. So let's say you're talking about going out for a walk and you walk 1 mile. If you walk or run at a faster pace, what happens is you use more energy per minute, but you exercise fewer minutes. So by the time you have walked 1 mile, you use essentially the same amount of energy, whether you do it fast or slow. It's just that you're burning more calories per minute, but you're out there fewer minutes. So the way that you use this is that you start walking the same distance, but you walk faster. So now you're improving your fitness somewhat at the same time, but it's the total distance that you cover. So it doesn't matter the difference how you do it, it's the total distance that's important, because for every mile, it's a certain number of calories for each individual. And if you go a little faster or a little slower, you still burn the same number of calories by the time you walk the same distance. Next slide. The other thing that's important is that energy expended can be accumulated. For example, if you did, for a lot of people, they say, oh, you should go out and exercise for 30 minutes. Well, that's not always easy for some people. 30 minutes, it takes a little more concentration, a little more effort to do that. But if you walk 3 times 10 minutes and you go the same distance, you'll have the same effect. And you can include the 10 minutes as part of your daily activity more easily if you do it that way. So, for example, if you're going to work on mass transit, you get off one stop early and walk 15 minutes to your work, and walk 15 minutes back. Or at lunch, you walk 10, 15 minutes to where you're going to have lunch and walk 10 or 15 minutes back, and then you've now added that as part of it. So it's easier to make part of your lifestyle. And if you say, I'm only going to walk for 10 minutes, maybe you can walk faster, and so that you go a further distance and therefore you burn up more calories. Now, next slide, please. How much exercise, how hard should you really work? As I said, if you're going to say your problem is, I only have so much time. Let's say I have 15 minutes to do this. Then the idea would be to do as much exercise as you can in that 15 minutes. And the one way to do that, the idea is to go as hard as you can, that can be done comfortably. Because that way in that 15 minutes, you'll burn more calories. And we have something called the talk test, that if I'm walking slowly, I can carry on a conversation, I can sing, but as I walk a little bit faster, then I start having to breathe a little bit harder, and I can't sing, or I can't talk as easily. And when I get to that point, right at that point, and maybe back off just a little bit from that so you can still talk, but that's the highest level that you can go and use the most amount of energy without it being uncomfortable. Now, that doesn't mean that at the end, when you start getting to the end of your allotted time, you can't walk faster during that period, to burn more calories. But the important thing is to do that test. Now, the other advantage of using the talk test is it's kind of hard for you to talk when you're by yourself. And that's why it's better to walk with someone else if you can. So, for example, it's also easier to motivate. It's more interesting. You have someone to talk to. And what happens sometimes is that you say, I'm not interested in walking today, but someone is waiting for me. And that other person saying, I don't feel like exercising today, but someone's waiting for me. And then the two people get together and they find they can walk more and they enjoy it. And once you get going, then it's no problem. Now, there was a question or comment about some of the problems of security of walking. And so some people have found by going to malls and walking there, especially in bad weather, you can get your walk in by walking through the mall with another person. And that way you can make it more interesting and make it more a part of your lifestyle. Next slide. Now, I'm sorry. Okay. Even though there may be modest effects of exercise on body weight, just by being active and reducing your caloric intake, they can have many beneficial effects on health. So it's not just the fact that you're losing weight, but you might also affect your health. So next slide. So overweight and obese people who are at increased risk of heart disease and type 2 diabetes, as a result of that, the next slide, they should participate. Next slide. They should participate regularly in physical activity and should improve their diet. Now, whether this better lifestyle causes a reduction in body weight or not, the important thing is you may improve your health. Now, there's a interesting thing going on now. We've always told people to be more active, but there is something called inactivity, that just being inactive causes problems that are different from being active. So what we say is you need to be less inactive and more active. Now, the interesting thing is just going from doing nothing to doing something, there are some major improvements in health risk and a reduction in all-cause mortality just from doing nothing to doing something. Now, it's better if you say, okay, follow the guidelines and exercise 150 minutes a week. Well, 2.5 hours over a week, that's a half hour, 5 days a week. A lot of people say, I don't have that amount of time. And so the important thing is do something. So maybe you're not getting enough in terms of the weight loss, but by doing something, you're improving your health markedly just by doing something. And it's hard to people understand that, but there's some things that happen when you sit all day long. And even people who exercise a half hour every day and follow the guidelines, then they go back and they sit in front of the television or the computer for 8 hours a day, they lose some of that benefit from the exercise. So you've got to be less inactive and more active, and you'll get a benefit. Next slide. So people ask me, what is the best exercise program for me to do? Well, it's really do what you enjoy and what you will do. Next slide. And if you'll do it often enough, long enough, and hard enough to use many calories. That's the key. There's no magic. There's no magic program that it can give you. If I tell you to go out and jog and you don't want to jog, and you don't enjoy it, you're not going to do it. So find the things that you like to do. Now, it's been mentioned several times as well that the Hispanics tend to be more culturally and they're together and doing things together. And there's a program at the University of Illinois in Chicago by Professors Marquez and Bustamante, in which they do dancing. And the people come there and you tell them to exercise, they won't come. But if you come there and you dance the cumbia and the salsa and the cha-cha and those things, they enjoy it. It's cultural, because for many people, and this is especially true for older people, physical activity is a social activity. And if you make it social and fun, they'll enjoy what they do and they'll do it more often. So this is a very quick summary. The main thing to do is to make activity part of your lifestyle. And if you do that, even if you don't lose as much weight as you would like, there's some health benefits, and that's important enough. Thank you very much for your attention.
Thank you, Dr. Skinner. So as a reminder, if you have any questions, please feel free to type them in the chat box. As soon as we end our panel session, we will start with the question and answer session. So our next topic is about solutions to addressing obesity in the United States within the political landscape. So let's welcome Ms. Nancy Glick, the Director of Food and Nutrition Policy at the National Consumers League, also known as NCL. Ms. Glick works closely with NCL's executive director and stakeholder organizations to develop policy positions. She is also responsible for education and advocacy campaigns on key issues like food insecurity, food safety, food waste, and food fraud, obesity, and more. Welcome, Ms. Glick.
Thank you so much. Well, let's get to it. I'd like to have my first slide. So I am talking today about politics, and it's a very interesting topic because you've heard everything up to now about obesity, the prevalence, the complications, how individuals can improve their lives. But when it gets down to it, policy is going to be very, very important in whether we make sure that people who need treatment are able to get their treatment. So I was asked today to talk about the political landscape and what we as individuals and as advocates can do. So I am calling this the good, the bad, and the ugly of the politics of obesity. Next slide. So obviously the clock is ticking. There's a lot going on in Congress. And what I'm saying here is that there is so much that is now known about obesity from a scientific perspective. There's treatments that really, really work. And yet where we are today is that the majority of adults with obesity are not getting care. And the reason for this has to do with the fact that we have not yet made a sale in Congress and with regulators and in states that really underscores the importance of this disease and connects the dots for people so that they don't have what I refer to as outdated thinking, which doesn't recognize how significant obesity is as a disease itself and as a contributor to chronic disease. And chronic disease in this country is breaking the bank. So if we can make the connection for policymakers, that will be very important. Next slide. So why should policymakers care? We've heard a lot at this point from our other speakers, but I'm just going to talk to you as if I was talking to a member of Congress. We spend a lot of time concentrating on cancer and diabetes and osteoarthritis and heart disease. And we have advocates who go to Congress and ask for more research dollars and more money for treatment centers, et cetera. We are overlooking the biggest disease, the most prevalent disease in the country, which is obesity. And if you can see my chart here, obesity dwarfs every other major chronic disease in terms of the numbers. That's because 42% of adult Americans have obesity, 110 million people. So AMA has gone on record as saying that obesity is a serious chronic disease that needs to be treated. But until we connect the dots so that our policymakers understand that they are overlooking the biggest disease, then, we will continue to be talking about, what we can do ourselves when we need to have more help in terms of getting good care. Next slide. So I use these numbers when I talk to congressional staffers who don't have a lot of time. They get, everybody's talking to them about different things. So I want to tell a story about obesity and why it is so important for policymakers to help us. And if you look at these numbers, they are in sort of inverse order. So it starts with the biggest, the biggest number, and it goes to the smallest. But together they tell a pretty impressive tale. So first is 1.72 trillion. Trillion is 12 zeros. So that's $172 trillion spent every year by our society on obesity, not just for medical care, but for productivity, for disability, and for premature deaths. Now, I was talking about the number of Americans. Here it says 108 million. So there's between 108 and 110 million Americans who have obesity. That is a lot of people. And so we need our policymakers to understand that, we will go to the mat as advocates for diseases that have a lot less people. Why aren't we doing this for obesity? 400,000 is the number of people who die every year from prematurely from obesity. That's the equivalent to smoking. So we need our policymakers to understand how big this problem is. And if they're worried about smoking, they should also be worried about obesity. Hey, Rich. The next is 230 That is the number of chronic diseases, and one of our previous speakers told you about them, that are directly related to obesity. What this means is that obesity is a comorbidity. The more the weight, the worse the other disease. The less the weight, the better the outcome. And as an example, people who have hypertension and lose 10% of their body weight can be in a situation where the hypertension goes away. So it's important to make these connections. Then comes 10%. That is the total number of Americans today who have ever been treated for obesity. Think about that. A very small number, and something that policymakers, I don't think, understand. And the final is 2%. That is about the number of people in this country who have access to these new anti-obesity medicines. And, you know, they save lives, they really help. So we need to change these numbers. Okay, next slide, please. So when you see these numbers, I think anybody who sees these numbers would be upset. But here's the problem. Insurers will pay for the diseases I talked about, but they won't pay for the disease of obesity. So, you know, in my opinion, we're cutting off our nose to spite our face. But how does this look at the federal level? Well, at the federal level, the Office of Personnel Management, those are the ones that pay for the employees, the federal employees, they get anti-obesity medicines. So does the veterans through the Veterans Administration, and military through TRICARE. But as you have heard, Medicare has not stepped up to the plate. Right now, if you have diabetes, then Medicare will pay for your anti-obesity medicines. And now if you have heart disease, Medicare will pay for AOMs. But otherwise, no seniors have access to these very important drugs. And this leaves millions of people at higher risk for disability, disease, and premature death. So that's the problem at the federal level. Well, what about at the state level? Well, it turns out that Medicaid has the most significant number of Americans who have obesity. That's where they get their treatment. And yet only 16 states include anti-obesity medicines as part of Medicaid. And almost all of them have restrictions. So even if the state covers it, you may be required to go on step therapy, or the amount of obesity, the extent of obesity where you would qualify is as a very large person. So a lot of people are being left out. We have these state employee plans and pension plans. And most of them these days either don't cover anti-obesity medicines, or they have very significant restrictions. So what are the stumbling blocks? Well, the biggest one is price. And I have to tell you, I have been doing briefings almost nonstop on this, trying to get Congress to pass TROA, which you just heard of, the Treat and Reduce Obesity Act. And I can tell my story and everybody will nod, and then they will say, but we can't afford it. I'm a cancer patient. I had a bone marrow transplant. The insurance company spent $500,000 so that you can see me here today. I think I'm worth it. And I think people with obesity are worth it. So part of the issue we need to do, our charge, is to try to change this narrative so that when we go through the extent of obesity, the cost of obesity, and the number of people who are getting care, we don't end up at a brick wall, which is, I get it, Nancy, but we can't afford it. So what we really need to do is tell a better story. And if we'll go to the next slide. So here's TROA, and this is sort of interesting, and I use it as sort of a, not only because it may be good news, but also because it shows that, you know, when you're dealing with policymakers, you have to be flexible. So the Treat and Reduce Obesity Act, or TROA, actually has been around since 2013. So that means that this particular Congress is the 10th one to take it up. And pretty much invariably in every Congress, we have bipartisan support, people who, you know, put out statements and say how important this is. And there's a lot of attention for it, and all the stakeholders get engaged. And you know, we've never had a situation where people have just said, you know, this is stupid. No, everybody agrees that there needs to be a this kind of legislation, because what it does is it solves the Medicare problem. And that is that in 2003, when Medicare Part D went into effect, weight loss medicines really were not at the stage where they are today. There were safety issues. So Medicare excluded the entire category. But 21 years later, they're still excluding the category, even though everything has changed in the science and in the treatments available. So we have not been able to get CMS directly to change its policy. So that's the importance of TROA, and it does two things. It requires CMS to cover seniors with obesity and gives them access to anti-obesity meds. And it also expands access to something called intensive behavioral therapy. It's a very good form of behavior modification. Right now, it's limited to physicians' offices, primary care, but there are many ways beyond that where people could get care, and most docs don't have an expert in their practices, so TROA would solve that problem. Well, this time, after all the other times, things have changed. When this bill got to the House Ways and Means Committee, there was again this consensus that yes, you know, TROA is a good thing, but the Republicans basically said cost was a, you know, would be a deal killer. And so what they did as a bipartisan group is they agreed on what they thought could be a price tag for this bill, which is $1 billion, which in the relative scheme of things ain't much, but it's something. And they crafted what we call a skinny TROA. And what the skinny TROA is for older Americans who are still in the workforce, still have commercial insurance, but are aging out because they are turning 65 and going on Medicare. This TROA would grandfather in those individuals. So CMS would cover their anti-obesity medicines if they have been on treatment for, I believe, up to a year. Do we love this? No, we don't. But here's the thing. The perfect cannot be the enemy of the good. And so what's interesting is all the major stakeholders, National Consumers League, the chronic disease groups, aging organizations, have all come together and said, you know, half a loaf is better than no loaf, and we need a win. Because if we can get a win, then we can improve TROA. And so where we are right now is it's passed through the first hurdle in the House, which is House Ways and Means. It's now in the House Energy and Commerce Committee, and we are working hard to tell members of that committee that all the organizations support this version. And we are hoping it will be reported out. And we're also working right now with the Senate to tell them that when it's reported out, to please get it into the final resolution bill. We think we can do it. So it goes to show that, all of their efforts can result in maybe a compromise, but a compromise is something. And that's where we're going right now. Next slide. Okay, so here's my suggestion. And that is that we have to change our narrative. We go in there and we talk, lots of people talk about the structures and the bills and, how Medicare works. I think we have to connect this right to us. So we have to talk about people, not cost. Other people are going to talk about cost, but we really need to relate obesity to the fact that this is the biggest chronic disease challenge we have. And if we can solve this challenge, we can really reduce chronic disease in this country. That means healthier lives, less costs, people living longer and living better. We need to do that not just as advocates, but we need to bring in real people. We need people to tell their stories. We need policymakers to understand that living with obesity is like living with diabetes and osteoarthritis and cancer, things where people, are able to get attention for their disease. And the reason is because in most cases, those people also have obesity. So we need to be able to bring in new stakeholders and new voices to really tell our story. And we need to make this really about us and our future, and do it in such a way that we can get beyond the head and into the heart, because this is what our role is as advocates, speaking for ourselves, being our own voices. And we also have to bring in our experts who are our doctors, our health professionals, those who work with us, those in the aging community who see the impact on people with obesity who are not getting care. So that again, it's a new frame in which we talk very personally about obesity, how big a problem it is, that you just can't put numbers on this. This is about our lives and our future. And finally, we need to then connect all that back to those numbers that I told you about. Because, if we bring in 1 or 2 people with obesity, they just represent 2 of 110 million Americans. So we need to be able to go in there and make this story one that people can really envision in a different way. And we'll see. Hopefully that works. And I think that may be the end of my story.
Oh,
Thank you, Nancy. And thanks to our entire panel gathered here today. Now that we have had our final speaker, we will move on to the question and answer session. Due to the time constraints, we will take a little bit like 2 questions. So my first one is, I believe it's for anyone, and it's the following. How can we advocate for the passing of the Treat and Reduce Obesity Act? This comes from a community member.
Well, I'm happy to take that one since we're doing it right now.
Yeah.
So I think as an individual, you have the ability to relate TROA directly to you. And why you care about obesity, what it would mean for you to be able to get this kind of coverage. You may not your situation may not apply to the new TROA that I talked about, but it would be important to say that, having a TROA is important as a first step in helping people like me get the coverage we need. And I hope in the future that we'll be able to make sure that CMS will cover everyone who needs this disease. But if we can really relate this to every person individually, I think, all of us advocates are going in there as advocates. But I think hearing from individuals, real people, that's a really good thing. And by the way, send it to your senator and your congressional members.
Christine, I would just add, I think Nancy's absolutely right. This is an issue that lends itself to being personalized in a way that will relate to people. And I think her other point is well taken too. The legislative process is not perfect, never will be. But if you have an opportunity to make a move and get something started, you should do it. This is the time to do it with TROA.
Thank you, Bob. Thank you, Nancy. And I have another question, again, for anyone who wants to answer it. Is what cultural factors contribute to higher obesity rates among Hispanic and Latinos, and how can we address them?
No, I think, as I mentioned, the involvement that I've had with Hispanics, I'm involved with programs of exercise for cancer, and we do it internationally. And the interesting thing in the States, a lot of the people like to exercise individually. When we go to Brazil or Mexico, they say, no, we want to get together as a group and do the dancing and do the exercise together. Because like I said, it can be a social activity. And if we're trying to make things cultural, and the Hispanics tend to be very open in that way, I think that's the way to do it, is get programs that involve everyone in the community, or as many as you can.
I agree. Thank you so much, Dr. Skinner. And again, thank you to our sponsors, speakers, and the attendees for joining us for today's virtual event. We encourage all of you to follow us in our NHCOA social media channels. You can find us in Facebook, in X, formerly known as Twitter, and Instagram by using the following handle, NHCOA, for more information about upcoming events. Let's all continue advocating for programs and also resources to better support older adults, their families, and caregivers. Until the next one, thank you. Gracias.
Interesting.
Thank you.